our health care. So when you get sick and go to the doctor, your doctor is getting reimbursed by a particular health plan for a rate that was negotiated between that doctor and that health plan. And all of those negotiations, all of the back and forth about how much that health plan is actually going to pay your doctor, and the doctor's appeal of that, and on, adds enormous cost to the system. Magnify that by the millions and millions and millions of healthcare transactions that occur every day, and you get a sense of the enormous share costs of administering our system. We spend a lot to administer our health insurance plans themselves with medical underwriting, marketing, high profits, and shareholder profits, and CEO salaries as well. Those are very high costs borne by our healthcare system. For all of those expenditures, and we have the most, obviously, the most expensive system in the world, for all of those expenditures, the quality of care in the United States is very uneven. It has very high points, which the President talked about, from the pinnacle of power, where the President of the United States has a physician who follows him constantly, everywhere he goes in the world. Members of Congress who are very well cared for through the Federal Employees Health Benefits Program, but down to many people in Los Angeles who have very poor access to care, and when they get care, it's often of very questionable quality. On average, the average American can expect that about half of the time they go to the doctor, they will receive the appropriate care for their condition. The other half of the time, they may not be getting care that they should be getting, or they may be getting care that will do them no good and may possibly do them some harm. We have inadequate health outcomes in our system. If you look at things like the kinds of conditions for which health care is effective in providing palliative or curative care or prevention, the United States does more poorly than some 19 other countries in the industrialized and economically developed world. Our population health indicators are near the bottom of all of the advanced economies and below that of a number of developing countries. 29th in the world in infant mortality rates, 30th in life expectancy at birth. We have disparities in care and in health in this country, which you would think that if we were spending over $7,000 on average per person in the country, we ought to not have. So these are the problems that the President set out to address in when he was campaigning for the office and since he has taken office, and the same issues that the Congress has taken up to address through health care reform. There is a consensus which has developed between the White House and the Democratic leadership in the Congress, in both houses of Congress. And there are now two bills that have emerged from the Congress, from the committees of the Congress. Neither one has been voted on by the respective House of the Congress, but the Senate Health Committee, which stands for Health, Education, Labor, and Pensions, has produced a bill that won a majority of committee votes, Democrats, in that Senate committee. Three committees in the House collectively wrote a single bill, which they produced, called now the Tri-Committee Health Care Reform Bill. And that bill has been voted on by two of those committees, the House Ways and Means Committee and the House Education and Labor Committee, and has yet to be voted on by the Energy and Commerce Committee, the third part of this three-legged stool in the House. But all of these bills that are coming from the Congress are attempting to address these broad problems. The lack of coverage and lack of affordable health care for people. Secondly, quality issues and outcomes in the system. And third, the rising costs of health care and efforts to hold down and lower that trend line. I want to address 7 key coverage and affordability issues that are addressed through this consensus process, because I think these are the core issues that most Americans care about. Americans will also care about some of the other issues, and I'll just touch on those at the end, but I want to focus first on these. Issue number 1 is that I would say there is a consensus across the aisles in the Congress that health insurance can no longer be allowed to exclude, health insurers can no longer be allowed to exclude people because of pre-existing conditions, because of the occupation they have. So insurance market reform is a given in this environment politically. And both the House bill and the Senate bills will end this exclusion of pre-existing conditions. They'll also limit medical underwriting to limit the rate band or the premiums that can be charged to people and exclude medical conditions as a basis of charging people more for their health insurance. This is something that the insurance industry agreed to early in this reform process. Second, there is also an agreement now that all adults and children will be required to purchase health insurance or to have it through a public program. All of the bills in the House now include this. The President campaigned against it, but he has accepted this as a condition. And this is the insurance industry's condition for agreeing to the exclusion of, that is to barring, excluding people because of pre-existing conditions. The third issue that there is broad agreement on is that individuals have to receive subsidies. Obviously, we can't require people to buy health insurance, and we can't expect them to buy health insurance if they don't have subsidies to help them buy it, if they aren't upper middle class people with substantial incomes that can afford the now average cost of a family plan of about $13,000 a year in the United States. The House and Senate Health Committee bills both provide subsidies up to 400% of the poverty level. I think that's about $88,000 a year for a family of 4, I believe. And people will receive more financial assistance if their incomes are lower. Fourth, Medicaid and S-CHIP will be reformed, creating a national eligibility standard at 133% of the poverty level. So we will eliminate categorical requirements, which means that unlike today, when Medicaid is open only to adults in families with dependent children, or to those who are disabled or elderly, under the new reforms, Medicaid will be open to all based on their income. And those below 133% of poverty will be eligible for Medicaid. Those above that level, up to 400% of poverty, would then get the subsidies through for private or public insurance coverage. Fifth, there will be employer responsibility, what is part of what they call shared responsibility.